But lots of other interesting things are coming up as well for treatment too. So we have now a variety of stimulation devices or less invasive surgery. Where do you think about employing stimulation, and how do you think about it in terms of what its efficacy is, Kate?
Sure. So again, similar to what Trevor said, the first step is really identifying and defining intractable epilepsy. And if a patient has intractable generalized epilepsy, the only device that currently is approved is the vagal nerve stimulator. The vast majority of patients, as we discussed at the beginning, have focal epilepsies, and if they have intractable focal epilepsy, the first thing I think of to do is to evaluate them for potential surgery, either a resective surgery, or now laser ablation is becoming increasingly popular as a less invasive option for potential cure. And the patients that I consider other types of stimulation, namely deep brain stimulation or responsive neurostimulation in the NeuroPace RNS device, those are patients that are not excellent candidates for a potentially curative surgery in almost all cases. And that may be because it's near eloquent cortex. They have multifocal disease, they have poorly localized disease, et cetera.
Yeah, so it's important to remember, I guess, with the stimulation that you're talking palliation. We're not talking about stopping seizures, and it's entirely different to say, well, I'll try stimulator rather than removing something. Your end point is quite different. On the other hand, as you mentioned, I think we found too that, for example, the stereotactic laser interstitial thermal ablation is something that we're doing more of. We've had quite a few patients who would not have considered surgery before who are now willing to do that because they're in and out of the hospital in 24 hours. Yeah. And we do surgery on Friday, they go home Saturday, and they're back to work on Monday. Yeah. And I've had more than one tell me on the day that they went home, they went to the mall to shop. They feel so well. Has that impacted your pediatric practice as much? And you know, I'm wondering too about hypothalamic hamartoma.
Yeah, well, we've been doing focus beam ultrasound as well for hypothalamic hamartomas, which is totally non-invasive. But the FDA are only allowing us to do it in certain populations. But absolutely, the laser ablation is exactly the scenario you're talking about. And sometimes patients won't even. You know, the scenario is that resective surgery in that patient will have a higher likelihood of success, but you end up doing laser ablation even though you may not be getting the entire epileptogenic zone because it's less invasive. So your success rate may end up not looking as good, but the procedure is so much better tolerated. And that's often a discussion we end up having.
And what is your experience in terms of patient compliance with some of these stimulation techniques? Because data has to be downloaded, patients have to come back frequently. Has that been a significant issue, or do you think patients are reasonably compliant by and large?
No, in general, it's one of the things that takes adherence away. So you have a programming device. The only thing that in some cases is running out of battery. So if you have frequent monitoring, you can detect that. But it's one of the advantages, I think, in the case of vagal nerve stimulation, the question that was never answered is what would that do for a naive patient? But it would be very attractive to not have to deal with toxicity or problems with adherence if it worked as good as pharmacological management. We'll never have that answer. But for the refractory patients, some of the advantages of having a potential benefit on mood, having a faster recovery post-ictally, makes a huge difference for some of those patients. So it's things that you can appreciate for the more affected patients. And so all these techniques, the laser ablation is incredibly much better accepted and tolerated because it's a less invasive procedure.
So within this menu of stimulation, is there a rational way to decide that someone is a better candidate for one type than another? Because we can do external stimulation, as vagus nerve, internal with responsive neurostimulation, internal with deep brain stimulation, and a variety of other things are being investigated. Is there a sensible way to make a decision now, or do you think it's, you have an algorithm that you use, or is it still in need of further development?
I definitely think it's the latter, that we, as a field, need better biomarkers to tell us which one of these devices, if that's where we are. We're at a place where we're deciding which of these 3 currently FDA-approved devices that is best for a patient. We don't have an algorithm. I have an internal algorithm. The devices, the intracranial devices, work about as well as one another. At least they weren't compared head-to-head, similar to the drugs. But some of the side effect profiles differ, and that could play a role. For instance, a patient with significant psychiatric comorbidity may be more appropriate for the RNS device versus deep brain stimulation based upon the data that we have right now. And the vagal nerve stimulator likely works a little less well than these other devices, but it's much less invasive. Another issue with the RNS device is that it is more complex for the patient, and in the adult population, that can play a role in whether we think that the patient has the ability to, as Mike was saying, download the data at home to the laptop and really appropriately use the device so that we can program it. That issue is not there with deep brain stimulation or the vagal nerve stimulator.
Yeah. What's impressed me is that with both both deep brain stimulation and responsive neurostimulation, that a percentage of patients have extended seizure-free periods. And unfortunately, we don't have data on VNS to know whether that happens as well. But that is somewhat hopeful.